Shoulder instability. Published by WordPress.com. Shoulder instability. Page 1, Introduction. Page 2, Classifications. Page 3, Anterior instability. Page 4, Treatment. Page 5, Posterior instability. Page 6, Multidirectional instability. Page 7, Inferior dislocation. Definitions. 1. Instability. Symptomatic inability to maintain the humeral head in the glenoid fossa. 2. Joint laxity. Passive translation of the humeral head across the glenoid cavity, more than normal, but asymptomatic with perfect function. 3. Dislocation. Complete loss of contact between articulating surfaces, total incongruity. And 4. Subluxation. Incomplete loss of contact between articulating surfaces. Anatomy of the glenohumeral joint. Type: ball and socket joint, 30% containment. Orientation: neck shaft angle, 130 degrees. Glenoid retroversion, 7 degrees. Humeral head retroversion, 30 degrees. Scapular anteversion, 30 degrees. Structure: biceps anchor and superior labrum contribute to joint stability. Stabilizers of the glenohumeral joint. 1. Static stabilizers. A. Bony stabilizers. Orientation of glenoid and humeral head. B. Labrum. Fibrocartilage lip attached to glenoid margins. Functions: deepens the glenoid cavity. Provides attachment for the biceps tendon and glenohumeral ligaments. C. Capsuloligamentous factors, primary static stabilizers. Coracohumeral ligament, provides posterior stability. Glenohumeral ligaments, thickened anterior capsule. Superior GH ligament, restraint in 0 degrees abduction. Prevent inferior instability. Middle GH ligament, restraint in 45 degrees abduction. Prevent anterior instability. Inferior GH ligament complex, restraint in 90 degrees abduction. Anterior band, stabilizes in external rotation. Prevent anterior instability. Posterior band, stabilizes in internal rotation. Prevent posterior instability. Other mechanisms. Intra-articular pressure, -4 mm of mercury. Adhesion-cohesion mechanism by synovial fluid. 2. Dynamic stabilizers. Rotator cuff muscles. Superior, supraspinatus, anterior, subscapularis, posterior, infraspinatus and teres minor. Long head of the biceps, stabilizes anteriorly. Parascapular muscles, contribute to scapular stability. Factors contributing to instability. 1. Bony factors. Poor fitting and lack of coverage between the humeral head and shallow glenoid, 30% containment. 2. Capsuloligamentous factors. Redundant capsule. And 3. Muscular factors. Inferior aspect is unsupported by muscles, quadrangular space. Published by WordPress.com. Classifications. 1. Acute traumatic dislocation, TUBS. Anterior, most common. Posterior, often missed on initial presentation. Superior, rare. Inferior, luxatio erecta. 2. Recurrent instability. Recurrent microinstability may result in dead arm syndrome, instability, rotator cuff pathology, or nerve compression. 3. Multidirectional instability, ambry. Laxity in multiple directions. A. Etiology. 1. Traumatic, macrotrauma or repetitive microtrauma. 2. Non-traumatic, often associated with ligamentous laxity. B. Degree. 1. Dislocation, complete loss of contact. 2. Subluxation, partial loss of contact. C. Direction. 1. Unidirectional, anterior, posterior, superior, or inferior. 2. Bidirectional. And 3. Multidirectional. D. Onset. 1. Congenital, rare, associated with bony abnormalities or birth injuries. 2. Acquired. acute, chronic, or recurrent. E. Volition. 1. Voluntary, can be actively dislocated by the patient. 2. Involuntary, occurs without patient control. Traumatic unilateral Bankart lesion, TUBS, and shoulder instability. Introduction. TUBS refers to traumatic, unilateral, Bankart lesion resulting in shoulder instability, typically requiring surgery. Epidemiology. Shoulder dislocations account for 90% of shoulder injuries with a high recurrence rate, particularly in teenagers, 2% of the population. Common presentation: anterior shoulder instability.